Welcome to this explainer on laparoscopic cholecystectomy. Let's dive directly into this high-yield, rapid-fire exam review without any delay.
Section 1. Surgical Principles. Focus strictly on the core surgical principles and port configurations. Which of the following is true regarding laparoscopic cholecystectomy? A. Open Haasen technique is not recommended in elective procedures. B. Conventionally, 4-port laparoscopic cholecystectomy is performed. C. Supraumbilical incision is not performed. D. Varus needle is used in open technique. Or E. Bleeding disorder is not a contraindication.
The correct answer is B. A standard laparoscopic cholecystectomy conventionally employs a 4-port configuration to establish adequate retraction and optimal visual axes. Specifically, we're talking about a 10mm optical port, a 10mm epigastric working port for your dissecting instruments, a 5mm right subcostal port for Hartmann's pouch retraction, and a 5mm right flank port for gallbladder fundus retraction.
Exam pearls. 3-port variation. Omitting the lateral fundal retractor port offers absolutely no significant reduction in postoperative pain or complication rates compared to the conventional 4-port approach. Haasen technique. This is an open method highly recommended in both elective and reoperative cases. Varus needle. This is strictly used for blind, closed access, never in open techniques. Absolute contraindications. Uncontrolled bleeding or major coagulation disorders absolutely prohibit laparoscopic surgery.
All of the following are relative contraindications of laparoscopic surgery except A. Overweight patient, B. Old age, C. Pregnancy, D. Acute cholecystitis, or E. Cirrhosis.
Correct answer is B, old age. Advanced age alone is not a contraindication to laparoscopic surgery. In fact, elderly patients frequently derive substantial benefits from minimal access procedures, including significantly reduced pulmonary complications, much less postoperative pain, and earlier mobilization. Options A, C, D, and E represent clinical scenarios that complicate laparoscopic access, classifying them firmly as relative contraindications.
Absolute versus relative contraindications. Absolute contraindications include uncorrected severe coagulopathy, generalized peritonitis, mechanical intestinal obstruction, severe COPD or ischemic heart disease due to hypercapnia intolerance, and hemodynamic instability. Relative contraindications include pregnancy, severe morbid obesity, advanced liver cirrhosis with portal hypertension, prior extensive upper abdominal surgery, and acute cholecystitis.
Which of the following is an absolute contraindication to laparoscopic cholecystectomy? A. Liver cirrhosis. B. Previous abdominal surgery. C. Obese patient. D. Pregnancy. Or E. Generalized peritonitis.
The correct answer is E. Generalized peritonitis signifies widespread intra-abdominal inflammation and septic exudate. Attempting laparoscopy under these conditions carries an unacceptably high risk of bowel perforation during port insertion. Plus, you'll have exceptionally poor visualization due to dilated bowel loops and an inability to adequately clear the abdominal cavity. This completely necessitates an immediate open exploratory laparotomy.
Exam pearls. Pathological rationale. Conditions like liver cirrhosis, structural adhesions, obesity, and pregnancy definitely require specialized technical modifications, like open Haasen access, but they don't prohibit a laparoscopic approach absolutely. Cardiopulmonary limits. Severe cardiopulmonary instability constitutes an absolute contraindication because the CO2 pneumoperitoneum drastically worsens hypercapnia and reduces cardiac output.
What should be the correct azimuth angle for maximum laparoscopic task performance? A. 15 degrees. B. 30 degrees. C. 60 degrees. D. 90 degrees. Or E. 120 degrees.
The answer is B. Based on the baseball diamond concept, laparoscopic task efficiency and precision are heavily governed by ergonomic angles. The ideal azimuth angle, which is the exact angle between an active working instrument and the optical axis of the laparoscope, should always be 30 degrees. This ensures perfectly balanced depth perception and minimizes instrument crossover.
Exam pearls. Manipulation angle. The optimal range is 60 degrees between the tips of the two working instruments. Deviating outside this range causes massive physical fatigue and loss of coordination. Elevation angle. The optimal angle is also 60 degrees between the instrument shaft and the horizontal plane of the patient's abdomen. You achieve this by ensuring half of the instrument shaft remains outside the abdominal port, essentially half in, half out.
A young patient is undergoing laparoscopic cholecystectomy. During creation of pneumoperitoneum, the patient develops sudden hypotension. Blood pressure falls from 120/80 to 80/60, with a pulse rate of 120 beats per minute. Which of the following seems to be the likely cause? A. Respiratory compromise. B. Decrease in venous return. C. Trauma to great vessels. D. Anaphylactic shock. Or E. None of the above.
The correct answer is B. Insufflating the abdomen with CO2 immediately increases intra-abdominal pressure. If those pressures rise excessively, the high pressure literally collapses the low-pressure intra-abdominal veins, specifically the inferior vena cava. This restricts venous return to the heart, leading to a massive sudden drop in cardiac preload, decreased stroke volume, and systemic hypotension. That hypotension is exactly what triggers the compensatory sinus tachycardia.
Exam pearls, positional exacerbation. Laparoscopic cholecystectomy requires the reverse Trendelenburg position. This directly causes blood to pool in the lower extremities due to gravity, which further decreases venous return and completely aggravates acute hypotension. Immediate management. If sudden hypotension happens during initial insufflation, your immediate step is to desufflate the abdomen by venting the ports, check the automated insufflator settings, and immediately administer intravenous fluid boluses.
Which of the following is an advantage of minimal access surgery? A. Improved visualization. B. Achievement of good hemostasis. C. Requirement of hand-eye coordination. D. Conversion to open procedure. Or E. Increased wound-associated complications.
The primary advantage is A. Minimal access surgery provides incredibly superior visualization compared to traditional open surgery. Modern high-definition laparoscopes easily deliver magnified, high-resolution, and perfectly illuminated views of deep anatomical recesses that are otherwise extremely difficult to visualize through standard open incisions.
Exam pearls. Wound benefits. Minimizing the size of the incision significantly lowers wound-related complications, like dehiscence, surgical site infections, incisional hernias, and severe post-operative incisional pain. Systemic advantages. Smaller incisions literally lead to decreased core body heat loss, a drastically reduced systemic metabolic stress response, and earlier post-operative mobilization. Inherent challenges? Requirements for advanced hand-eye coordination, total loss of haptic tactile feedback, and the risk of converting to an open procedure are inherent limitations of laparoscopy, not advantages.
Which of the following is the appropriate position while performing a laparoscopic cholecystectomy? A. Prone position. B. Trendelenburg position. C. Trendelenburg position with a right tilt. D. Trendelenburg position with a left tilt. Or E. Reverse Trendelenburg position with a left tilt.
The correct answer is E. Laparoscopic cholecystectomy strictly requires a reverse Trendelenburg position combined with a left lateral tilt. This incredibly specific alignment directly leverages gravity to shift the highly mobile transverse colon and greater omentum downward and completely toward the left lower quadrant. This perfectly exposes the right upper quadrant and Collat's triangle.
Exam pearls. Reverse Trendelenburg. This consistently displaces the stomach and duodenum caudally, moving them safely away from the liver bed. Left lateral tilt. This effectively rotates the hepatic flexure of the colon downward and away, making the right hypochondrium prominent to facilitate totally stable instrument manipulation. Hemodynamic trade-off. While this is optimal for surgical visualization, this exact position inherently reduces venous return and can easily cause intraoperative hypotension if it's combined with high abdominal insufflation pressures.
If reverse Trendelenburg optimizes visualization but compromises venous return, how do you balance surgical exposure with hemodynamic safety during a prolonged case?